and hope you can see my slides now. Can you
Yes,
see?
we can.
Okay, fine. So that's the place where I work, and that's where we have our research institute from where all these papers come out. So moving on, let me first tell you what are growth charts, and more importantly, like the under 5 mortality speaks of health status of a nation, a growth chart speaks of health and disease in a child. Hence, they are also known as road to health. Now, it's such a powerful tool. You just heard Professor Raghupati quoting some of his experiences from Australia. And anthropometry is such a powerful tool in the hands of pediatricians and endocrinologists that in Australia, you actually do not even need a growth hormone stimulation test to start growth hormone on a patient. You actually need the anthropometric proof over a period of time. That is the importance of anthropometry. Now, normally, what parameters do you as pediatricians assess? You assess the height or length, weight, head circumference in the first 3 years, body mass index, upper and lower segment, waist circumference. You heard Dr. Shaila speak of waist circumference, and other things such as, say, skin fold thickness or wrist circumference can be either clinical or research tools. Now, anthropometric data collected over several thousand of children makes it possible to produce growth charts. So primarily, your growth charts are graphical representation of statistically smooth percentile values. And growth charts are much better as compared to your tables, because in table, there is no continuity, whereas in charts, you get a very good visual impression of the actual growth curve. So it is best to use growth charts and not tables like about 20-30 years ago some pediatricians used to use. But let's first understand our charts. Now you all know that these are the IAP simplified WHO growth charts, where the IAP has given you the length, head and weight parameters on a single page. Whereas if you download them from WHO website, you will have 8 pages if you take 2 sexes together, or 4 pages per child. So what the chart actually shows you is the length, head and weight, but there are 4 lines, unlike the 7 percentile lines that you see in the original WHO chart. So these have been simplified. But more importantly, the average line is in the middle. The top line is the 97th percentile or the +2 Z-score. And the orange line is -2 Z-score. And the red line is -3 Z-score. So you have upper limit of normal, average, lower limit of normal, and very abnormal. For the head circumference, however, only the 3rd percentile has been depicted, because I think you're not really supposed to wait until it drops below the 3rd percentile. For weight, again, you have 2 similar lines. The orange is the -2 Z-score, and -3 is the red line. Now, a lot of us do not somehow use the weight for length or height chart. But please remember, these are the BMI equivalent of older children. So whenever there is a child with failure to thrive in question, you must surely look at these charts. Now, as you know, these are age independent. What you need is the length on the x-axis and weight on the y-axis. And again, you have 4 lines. The top line is the 97th percentile. The middle line is the average line. And the orange arrow is the -2 Z-score. And the red is the -3 Z-score. Or what WHO defines as moderate acute malnutrition is the orange line, and severe acute malnutrition is the red line. But I would like to remind you that somehow on WHO's booklets and website, it's very clear that MAM and SAM terminology should not be used in the first 6 months. They're usually reserved for children beyond 6 months of age. So these are the IAP growth charts from 5 to 18-year-old. You have 7 percentile lines here. Again, the top line is the 97th or plus 2 z-score, 0 z-score or 50th is the average, and minus 2 z-score or third percentile is the lower limit of normal, and same is true for weight. However, the BMI charts, and you did hear Dr. Shaila speak about this, that for the BMI charts, you actually have two different lines. They are overweight lines and obese line. But how are they defined? They are defined as 23 adult equivalent and 27 adult equivalent respectively. Now, why 23 and 27 and not 25 and 30 like in the WHO chart? The reason is, somebody did ask this question in the earlier lecture, the why paradox. See, an Asian Indian, that's us, we actually are much fatter at a given BMI. What it means is that the proportion of body fat in Indian children is much higher as compared to the Caucasian children at a given BMI. So you need to lower the BMI cutoff so that you pick up the metabolic syndrome variables at a lower BMI. So this is WHO's recommendation that for Asians as adults, you keep 23 for overweight and 27 for adult. And the IAP has provided you with the children equivalent of that by statistically fitting these lines. Now, as I said, how do you assess growth? Use growth charts. Charts are better than tables. But as Dr. Raghupati again and again in his talk very elegantly showed you, that longitudinal data plotted over a period of time is far more valuable than a single isolated reading. He could only diagnose CDGP because of the longitudinal plotting of the data. Another important consideration is to take birth weight and gestational age into consideration when you plot growth charts in young children. Up to 2 years of age, you should correct for prematurity, and beyond 2 years of age, you do not need to correct for prematurity. Now, you all are aware that in 2015, the Indian Academy of Pediatrics wrote these guidelines, and they also gave the revised IAP growth charts for height, weight, and body mass index for 5 to 18-year-old children. And I just showed you those charts. So that just, once again, the graphical images of what is available. All these are available on the web. You can download and use them. For routine clinical use, you do not need any permissions. Now the next question is, how do you adjust for the mid-parental height? Now the way you adjust for mid-parental height, which is also known as the adjusted mid-parental height or target height, you take mother's height plus father's height plus 13/2 in centimeters, and for girls minus 13/2. And then you plot it at 18 years of age on the chart. And the mid-parental range is taken between 6 to 9 centimeters above and below the target height. Now this 6 to 9 range comes from plus 1 SD, plus 1.5 SD, or plus 2 SD around the mean. Let us look at an example. Now here is a kid who is on the 3rd percentile, as you can see on the graph. Now his weight is also below the 3rd percentile. So we plot his height and weight. So that's where his mid-parental height is, and that's the mid-parental range here on the right side of your screen at 18 years of age. And now using your drawing skills, you can actually draw a percentile, which is the lowest percentile for this family. Now, when you use 6 centimeters as the spread, you have 10th to 90th percentile for this particular family. So you are now creating a specific chart for this family so that all boys of this family should fall within these 3 percentile lines. That's how you correct for mid-parental height. Now in 2021, we produced the Pediatrician Friendly Growth charts. And these charts are particularly useful because we have eliminated all the calculations from your chart. Now, I fully understand that pediatricians are a busy lot. Doing calculations is difficult. Calculating BMI is one more step, or calculating mid-parental height is even further step. So what we have tried to do now is to give you 2 tools on the existing IAP charts This tool, which Dr. Shaila briefly touched upon, is called the Quick BMI Lookup Tool and is applicable for children between 8 and 18 years. And this is to calculate the mid-parental height. Now let us see how it works. Now see, no calculation is going to be required here for BMI, and no calculation of MPH is going to be required here. Let us see how. This is the BMI tool. So all that you need to do is, just like I showed you weight for length in under 5 children, you plot the weight on the y-axis for the given height on the x-axis. And let's see how it works. Let's take the first example. You have a 135 centimeter boy who weighs 30 kilos. Now you can see by joining these two axes, you get a dot here. So this child falls within the normal range. The same height, but weight of 35 kilos. And you see she now falls in the overweight range. If the same child with a height of 135 had a weight of 45 kilos, then she falls now in the obese category. And if at the same height, this girl had a weight of 20 kilos, she becomes underweight. So these quick BMI lookup tool for 8 to 18-year-old children makes it very easy to use a screening tool to quickly see, am I looking at a patient who is obese, like Dr. Shaila showed, a child standing there with a t-shirt on, you will not sometimes understand that this child is actually obese. But plot it on the tool and you will immediately recognize that this child is abnormal. And similarly, let's take an example of a mother who is 157 and dad who is 170. By using our calculations, we know that the mid-parental height is 157. How does it work on this tool? Father 170, mother 150. All that you do is you join these 2 points. And in the middle, you read that now the mid-parental percentile is between 25th and 50th and is closer to the 50th. So you can quickly look at the child, and if the child is below 2 major percentile lines as compared to the percentile given here, you know that the child is abnormal. So the same thing plotted here on the growth chart, that's where the girl's height is, that's where the weight is. Using our BMI tool right here, you don't need to do any calculations of the BMI. You straight away look it up here. This child is obese. And the mid-parental height, which I got from the calculation here, is plotted just under the 50th percentile. And by joining these 2 numbers, here again, you have a quick lookup tool for MPH that shows you the same. So in the pediatrician friendly growth charts, the IAP has eliminated all your calculations. So it has made, I hope, life simpler for the pediatrician in a busy OPD to look at these 2 parameters. Now, you looked at the height velocity, which Professor Raghupati showed. Now we have the Indian height velocity chart. We have been following J.M. Tanner's charts for many, many years. And in last few years, we have done longitudinal study for 7 years across India. And we have produced the Indian growth velocity charts, which are published in Indian Pediatrics in 2019. So you now have Indian growth velocity charts for boys and girls. And if you compare them with Tanner, the mean height velocity is a little lower in Indian children, particularly so in case of girls. And just a reminder that on growth velocity charts, your cutoff for danger is 25th percentile and not the 3rd percentile like in normal distance growth charts. These are the simplified height velocity based on those charts. Is in the first year, you grow 24 centimeter, second year 12, third year 6. In the 4th year, till puberty, you grow about 5 centimeters a year. And in puberty, it is anything between 8 to 12 centimeters, and you should refer to those velocity charts. Now, you heard Dr. Shaila speak of obesity. Obesity is a pandemic, and it's going to be worse with the lockdowns. These are the old figures, and I think Dr. Shaila also showed the same figures. I have already mentioned this, so I'll skip a couple of slides, and I'll straight away go to the danger of metabolic syndrome in adolescents. Now see, Indians are particularly prone for metabolic syndrome because of their propensity to have central body fat and relatively low lean body mass. But there are about 10 definitions of metabolic syndrome available in children, but the most accepted definition as of today is the IDF. And as you can see, there is a paradigm shift. There is a paradigm shift in the way metabolic syndrome is defined in children, that the primary starting point is the waist circumference. And in the recent update, it's very clearly given that you either use above 90th percentile for NHA-NES for countries where no waist charts are available, but for countries where there are appropriate ethnic charts available, please use those. And then presence of 2 or more of these 4, that is hypertriglyceridemia, low HDL, hypertension, and fasting impaired glucose. So we have actually produced the Indian waist circumference charts, which are published in the American Journal of Pediatrics in 2014, and this is the paper. And these waist circumference charts look like this. You have charts for girls and you have charts for boys. And we have highlighted 70th percentile instead of 90th. The reason is our study actually showed, which has been echoed by some workers like Dr. Anurag Bajpayee and Himchand Prasad, is that at 70th percentile of waist circumference, you already start showing the metabolic risk factors. So maybe it's okay for a Caucasian child to stick to 90th percentile, but in India, perhaps we will even have to lower the waist circumference. Now, proportions. We all have grown up as pediatricians learning that at birth, the upper segment, lower segment ratio is 1.7. It becomes 1.3:1 at 3 years. It becomes 0.9 at 9 years and becomes nearly 1 after adolescence. This is based on the Caucasian data. Now, India is a vast country with so many ethnic variations. Is this true? So we have now produced Indian upper segment, lower segment ratios, as well as we have produced sitting height and subischial leg length chart for Indian children, which are published in the Annals of Human Biology. And you can use them for Indian children. What is important to remember is that the discrepancy between the upper segment and lower segment should be more than 2 standard deviation on the charts to say that my patient has disproportionate short stature. Now, in 2020, we wrote this paper in Journal of Pediatric Endocrinology and Metabolism, the European journal, and we have produced extended growth charts. These are of particular use for pediatric endocrinologists and endocrinologists. Now, these are needed for diagnosis of severity of short stature. They are also necessary for deciding when to treat a child who has short stature due to SGA, idiopathic short stature, and syndromic short stature. So these are the extended growth charts where we have given you -2.5, -2.25, and -3 z-score on the existing IAP-WHO combo charts. So here you can see that the red one is for severe syndromic short stature, the orange one is for SGA, the dark brown is for SGA, and the orange one is for idiopathic short stature. So you don't need to go back to your IAP spreadsheet and calculate the z-score. Here you can directly get it just by plotting on the growth chart. So extended growth charts are very useful for people who are pediatric endocrinologists and endocrinologists. Now, why we have produced these charts? Why Indian? Why I'm saying make in India? Now look at this CDC charts 3rd percentile for a girl versus the Indian 3rd percentile. If you are going to produce or treat a child who is below the 3rd percentile based on the CDC chart, see how many more children you would unnecessarily treat. How many more children you would unnecessarily treat. So you should use Indian data while deciding whether your patient actually qualifies for treatment with growth hormone. That's the American 3rd centile, and that's the Indian 3rd centile. Now I'm going to take you on a short journey of something very new and novel called the synthetic growth charts. Now, let me first introduce this concept that variations in the human growth have been attributed to genetic, nutrition, and health-related and socioeconomic circumstances. Despite all this, human growth curves across the world show certain common characteristics. Therefore, a very large global database was set where more than 200 studies over the last 50 plus years was constructed, and regression equations were designed from this global data to determine the median for height and weight at all 5 key ages. And then, based on that global database and the regression equation, you can load the country specific data points onto those equations and produce your growth charts. But you also need to have the spread. Now, as some of you may know, height is a normally distributed variable, whereas weight is actually a variable which is skewed to the right. So you have to have what are known as the LMS values, which are produced from the global data. That is your lambda, your mu, and your sigma, which can help you to produce country-specific percentiles. I would just like to ask the administrator, why am I getting these lines on my screen? I think somebody else's screen is active. Can you please delete those yellow lines which are coming on my screen?
So actually, I don't think any other screen is active either.
Okay, but now that line is gone, so somebody is playing with it. Yeah, and even that yellow line has been sitting there for a while. But anyhow, let's move on. So the basic components that you need to produce growth, synthetic growth charts, are you need only these parameters at these key ages, which are birth, 2 years, 6 years, 12 years for girls, 14 years for boys, 15 years at girls, and 18 years for boys. Now, why am I telling you about this exercise? The reason is, in a country like India, which is so vast, producing charts requires an unbelievable amount of effort to keep on collecting data decade after decade after decade, and that too over people who grow in the good nutrition and good health. So it all then becomes a private exercise. No government agency is doing this for you. The NFHS survey, if you look at them, even the most recent, the representation of the well-off people is not even 5%. So you cannot produce growth charts from that data. So then if you have to collect 100,000 children's data across India like we did in 2007, it becomes a huge exercise. It's very cumbersome, it's extremely expensive, and to be honest, it's not possible decade after decade without any government funding, and government is least bothered about giving you any funding whatsoever for producing your own country's references. Hence this method. What this method actually gives you is that you only need to have means of representative sections. So limited data taken on the right population and just plug it into the global model. So let's move on. From this, you produce these means for weight and height. And then using complicated regression equations, which are nonlinear regression equation, you join the means. So you then have the country-specific median curves for weight and length. Now you smoothen these medians using Priest-Benz equations. Now Priest-Benz modeling, I won't go into the detail, but these are some of the most well-fitted models to human growth. So if there is any aberration in your statistical prediction, these models will correct it. And for under 2 years, you use the Jolly core model. So putting these two things together, you then smoothen the growth curves. And then you use global L and S values to produce the weight and BMI, and global LMS values to produce this height charts. And this is what you get. So you get this beautifully designed charts just based on representative data of your country, and you don't have to do the mammoth exercise of collecting this data again and again and over again. This will also show you your country's secular trend because you are putting the local parameters on the global model. So doing all this, we produce the synthetic growth charts for Indian children, which are published in the Indian Journal of Endocrinology and Metabolism in 2019, December. And for all those who are interested in seeing the difference between IAP growth charts and the synthetic growth chart, here is the paper which is very freely available. And interestingly, there's almost no difference between the IAP charts between 5 to 18 and these charts. But the strength of these charts is that here you have 0 to 5 years Indian chart. Because as pediatrician, 90% of you will agree with me that on WHO growth charts, nearly 30% of children in the urban area and 40 to 50% of children in the rural area are below the third percentile for length and weight on WHO charts. So let me show you an example here of how it works out when I look at 2 children with failure to thrive. Now let's take example of this 12-month-old boy with a length of 72, weight 7.5 kilo, and another boy who is 36 months, 90 centimeter, 11 kilos. Now let me plot here. I have plotted the first boy. His height is on the third percentile. His weight is on the third percentile or just below the third percentile. And the second boy's height is just above the third percentile and the weight is below the third percentile. And for weight for length WHO chart, both the children are actually failing to thrive. They are below the third percentile of the WHO chart, or what is known as the moderate acute malnutrition. Now we thoroughly investigated these children because they are man. All tests came back normal. Their parents are not very tall and the family is slim. Now we put the same data on Indian synthetic growth chart and this is what you get. What you get here is that in both children, they are all right for their length, and for the weight, the first one is on the third percentile and the second one is the second one is on the third percentile and the first one is between the first and the third percentile. Now plot them on weight for length, Indian synthetic growth charts, and you see that both the children are above the orange line. Once again, mind you that these children's all tests were normal. So if we would have used the synthetic growth charts on these children without any symptoms, without any signs of disorders, we would not have unnecessarily investigated these children. So I'm not making a point at this time that maybe synthetic charts are better. All that I'm saying is that this possibility needs to be explored. And there are at least 120 papers today in the world literature which say that WHO growth chart, which say one size fits all, is inappropriate for majority of the third world country and a lot of even European countries. So I think this is a food for thought for you. Now there are lots of software tools which IIP has produced, and Dr. Raghupati sir had shown that data, handwritten data, which is so nicely kept by the parent. But in this day and age where young parents are so tech savvy, all that they need to do is go to the go to the Google website, download our IIP growth chart application, which is completely free. This application draws the graphs for you, it interprets for you. So parents actually, many of my patients do plot this on their own phones and show me the growth charts. So I urge you all to encourage your patients to actually save their child's data, plot it, and next time when they come, just show you the growth chart. It becomes so easy for you. Now, we have also designed some software tools for the researcher. Those who are interested can write to me. All this data which I showed you, I have put together in Excel templates. So anybody who is doing research, maybe it's a PG student, it's a clinician, a researcher, if you want to calculate Z-score for any parameter, including even Indian systolic and diastolic blood pressure, you can just put your numbers here and you will get the Z-scores here. So this is particularly meant for researcher, but anybody can use them. We have designed multiple tools, like we have this Tanner Whitehouse scoring, and you can get a height prediction. I have kept all these tools royalty free because I want people to use them and then give me a feedback. Now, before I end, there is an Indian Society of Pediatric and Adolescent Endocrinology conference in 2021 in Pune, and hoping that there will be no third wave of pandemic, this will be a physical conference. And we have a galaxy of international speakers, and we have 3 days of Feast of Pediatric Endocrinology, which is actually preceded by a SP PET Fellow School, which is a 3-day compact, really packed program, which is going to happen at the Corinthian Club in Pune. And I urge all of you who are interested in pediatric endocrinology to register for this meeting. And last day is only for pediatrician. And this is the website, www.ispepune2021.com. Anybody interested, please register. Still, we have the early bird registration open. And should it unfortunately go all virtual, then your half of your registration fee will be returned. So with that, I would like to once again thank my chairpersons and all my colleagues and friends who have been patiently listening to this, and for IIP Tamil Nadu, and most importantly, the Central IIP, to give me an opportunity to produce IIP growth charts, which will be used for pediatricians in this country. Thank you very much.
Thank you very much for that real, clear and wonderful session, sir. We are running short of time, so I'll just allow 2 questions, sir. These pediatrician friendly growth tools are really appearing, real exciting tools, sir, because calculating BMI and mid-parental height is a real cumbersome job, and you have simplified this. And Indian synthetic growth chart, we'll have to get used to the terminology and to the charts probably. Maybe one question, sir. What discrepancy between the parental height centile and the individual height centile should we intervene?
It is minus 1.5 Z-score, but since Z-scores are slightly hard to interpret for practicing people, I would say if you have 2 major centile line discrepancies, so if your mid-parental height is on the 50th and the kid is on the 3rd or even 10th, then that is